Ya puede empezar, doctor.
Okay, good afternoon, everybody. Thank you for being here. My name is Arturo Chayet, and today we have our monthly academic session. We have this live webinar. We are very pleased to have today as our guest speaker, Dr. Simon Fung from UCLA. And today our webinar is on an update on pediatric keratoplasty. So our agenda will be, we will start with a case presentation, and then we will have Dr. Fung presenting his lecture on the update on pediatric keratoplasty. I would like to thank my associates, Dr. Valdez, who's the Chief of Ophthalmopediatric Surgery at CODET, and also Dr. Denise Pincus, who is a co-director of the Cornea service at CODET. And so without anything, I'm gonna present you Dr. Mariana Tabares, which is our fellow in pediatric ophthalmology. She's gonna present us a very interesting case on a pediatric keratoplasty. So Dr. Tabares, I'm gonna stop sharing. You can start sharing your screen. Thank you very much, everybody, for being here.
Hi, good evening. I'm Dr. Mariana Tabares. I'm currently doing the Fellowship of Pediatric Ophthalmology and Strabismus. I'm going to present you the next case. It's the case of an 8-year-old female who went to emergency consultation because she complained of red eye pain and the appearance of a white dot in the right eye 8 days before. She was treated with a cyclovir ointment and pills, psychoplegic and topical ketorolac. Mom mentioned about a viral infection in the red eye when she was 8 months old that improves with a cyclovir. The rest of the medical history was irrelevant for the case. The visual acuity of the patient was point fingers of the right eye and 20/20 for the left eye. The diagnosis of infections keratitis was made with probable herpetic keratitis, rule out of bacterial ethology. We performed a corneal scraping, which was inconclusive, and started treatment with vancomycin and gentamicin drops, sorbirax ointment, oral acyclovir, and the patient was seen every day, the first week, and every third day until we complete an improvement of 15 days. 2 months later, the onset of the symptoms, the patient persisted with the same visual acuity, secondary to a residual central stromal scar. The visual acuity was pointing fingers, and at this point, the patient was treated with the steroidal drops to reduce the glaucoma size, and prophylaxis acyclovir was maintained for 8 months with no further recurrences were observed. And this topography, we can observe the cornea with an irregular pattern with diffuse thinning in the superior temporal area of the right eye, which set us an idea of how the size of the glaucoma impact the visual acuity of the patient. So that's why 1 year after the onset of the symptoms, the patient underwent a corneal transplant, performing a deep anterior lamellar keratoplasty in the right eye by big bubble technique. The size of the donor and the recipient graft was 8 millimeters, non-complications during the surgery. The follow-up, the postoperative patient follow-up was 1 day after surgery, daily for the first week of the surgery, weekly until the 3rd week of the surgery, monthly for the first 3 months, every 2 months during the first year, and the suture removing started 1 month after dog. The immediate treatment was oral acyclovir antibiotic drops, prednisolone drop every hour, and acyclovir ointment 3 times daily. 1 month later, after the surgery, the visual acuity of the patient was 2100, when the best corrected visual acuity of the 2060. The treatment that she has was as sorbirax ointment, antibiotic drops once daily, prednisolone drops once a day, oral acyclovir once a day, and the patient just the first month presented a superior neovascularization in the donor cornea, which improved with asteroids. And the rest of the follow-up the first year was uneventful. 1 year after the keratoplasty, the patient started with nomular infiltrates in the donor cornea without visual acuity compromise. Antibiotic and steroid drops were started 4 times daily and tapered every month, keeping 1 drop a day. After this treatment, we initiated tacrolimus ointment to prevent infiltrates and avoid further neovascularization or rejection. A patching therapy was initiated 1 year after the surgery, and the best corrected visual acuity in this moment for the right eye was 2050. The last visit of the patient to our service was, that is 3 years after the surgery. The patient remains stable. The last visual acuity that she achieves with scleral contact lens was 2030, and the refraction was the following, without a high cylinder of 80.50 in the left, in the right eye, sorry. The sensory tests were good with stereopsis and normal contrast sensitivity. The sleep lab illumination was good with a clear corneal button, non-vascularization, intraocular pressure of 12, and a normal fundoscopy. The actual treatment that she had is prednisolone drop once daily and tacrolimus ointment daily. And the next slide is showing the most recent corneal topography. Now it's a little more regular astigmatism, although it's against the rule, with a good corneal central thickness. We have the next discussion. Some corneal opacities have other ocular or systemic associations, which may limit the final visual potential or increase the complexity of the patient care. Age of the time of the primary keratoplasty may not significantly affect graft outcomes, but it has a visual outcomes. Risk of allograft rejection in dog is significantly less as compared to penetrative keratoplasty, and post-dog astigmatism may be not lower than PKP, but visual rehabilitation may be faster. In conclusion, visual rehabilitation remains challenging, in which it's necessary to have a multidisciplinary team, an experimented corneal surgeon, a devout pediatric ophthalmologist, and a pediatric anesthesiologist. These three cohesive contributing a factor plays an important role in success, and treatment adherence and involving parents are the key for visual outcomes. Dog after BHSBK in children may not prevent rejection, although it may be lower than after PKP, and long-term use of topical steroids and oral acyclovir appears to be needed in corneal transplantation after HSBK in children. And tacrolimus may play a role to decrease rejection rate and to decrease the dose of topical steroid needed. And that's all. Thank you.
Thank you very much, Mariana. So now what I'm gonna do is I'm gonna share back my screen to present Dr. Fung. Okay, very good. So thank you very much, Mariana. That was a very interesting case. And let's see. Perfect. So It's a really pleasure and an honor to have a rising star in cornea surgery, specifically in children cornea transplantation, by having Dr. Simon Fung. Dr. Fung did his corneal refractive and external disease fellowship at the prestigious Moorfields Eye Hospital in England. And then he did a pediatric corneal and external disease fellowship at the Hospital for Sick Children in Toronto, Canada. He's now part of the staff at UCLA at the Pediatric Ophthalmology Corneal and External Disease Service at the UCLA Stein Eye Institute, and he's assistant professor at the Department of Ophthalmology at UCLA. He's also in the editorial board member for the Journal of Pediatric Ophthalmology and Strabismus. And I can't think of anybody better at this point to present us an update of corneal transplantation in children. So I'm gonna stop sharing my slide. And again, Simon, thank you very much for being today with us. And please start sharing your presentation, and we'll be here to listen. Thank you.
Okay, let me just make sure. Let me see. So I'm sure everyone can see this, I hope. And
yes.
I'm just gonna just moving something around. So thank you so much for the kind introduction, and really the honor is mine that we got together and you for a kind invitation to speak at tonight's webinar. It's always nice because pediatric ophthalmologists or pediatric anterior segment surgeons, we don't usually attract much attention. So to be asked to actually give a talk is really true honor, especially from no other than Dr. Chayet, and I believe, I think Dr. Brown, I can see Professor Brown's name there as well. So the honor really truly is mine. So I thought tonight I'll give an update on pediatric keratoplasty. I have no financial interest in this talk. Now, without the introduction, I would have done something about my background, but I think I would still give you a little bit of background on how I form my perspective. I need to make sure I can, okay. So originally from Hong Kong, I did my medical and training and residency in England. And during my fellowship, after my residency in Moorfields, I realized that pediatric cornea and anterior segment is an area that is an area of unmet need. So I went on to undertake the only pediatric corneal fellowship in Toronto, and really is the only one of its kind in the world. And I was the second of the so far 4 fellows who have graduated from this program. And we were then sent to 4 corners of the world, so we don't see each other very often. This unique training path helped me to understand the key aspects of cornea, but also how to transfer some of the skills from adult to the pediatric setting, and also how to interact and manage pediatric patients as well as their family. I think it's important that we realize children are not just merely small adults. Since I joined UCLA about 2 years ago, I'm glad to say I have met some really esteemed colleagues and also amazing teammates. And then, including these 2, I think everybody knows who they are from last night's game. So, but I digress. I wouldn't go on anymore. So I thought first of all, let's just have a look at where do we come from. I think it's always important to look back and see where the idea of pediatric keratoplasty or any subject take root in the first place. And I would say yes, for most of the ophthalmologists, pediatric keratoplasty is something that is uncommonly encountered. And truth be told, until I think in the early parts of 20th century, there was only been fleeting reports of this particular surgery being done. The dawn of pediatric keratoplasty, I would say, it didn't start until Professor Stewart Brown published his series after series after series of papers on this topic since the early 70s. And therefore, to have him in the audience here really is a true honor. Since then, we have gradually gained a lot more understanding of the condition, as well as the surgical outcomes. And Last year was 50 years since Dr. Brown's first report. Really it's an honor to share my little contribution to the field as outlined in my review in 2017. Now, before getting to how the surgery is done, I think we should talk about the not so common entities of pediatric corneal opacities, first of all. Among the corneal etiologies, by far the most common is Peters anomaly. Next is probably anterior segment dysgenesis. It's a group of conditions including Axenfeld-Rieger syndrome. And sometimes it could be quite difficult to differentiate one from another. Other entities, including the acquired ones, such as corneal scarring. This particular one in here is from Hapstria. Keratoconus is relatively uncommon. I think after all, it really is a young adult rather than a pediatric disease. But from time to time, we do see some corneal trauma that can lead to significant corneal scarring. Now, most of the limbodermoid that we see down here does not need a transplant, but a corneal dermoid of this severity certainly needed one. Even less common, I would say, would be the metabolic condition, such as this one here. This is seen in mucopolysaccharidosis. And in this region, endothelial dystrophy, such as congenital hereditary endothelial dystrophy, and also PPCD, posterior polymorphous corneal dystrophy, are not so common. But it's important to realize that there are important geographical differences in the disease prevalences, and endothelial dystrophy in Asia and Middle East is much more common. To differentiate the different diagnoses and to fully investigate the task at hand, I find that diagnostic imaging is very important. And certainly I use many, if not all, of these modalities in assessing my patients. Clinical genetics is also becoming increasingly useful because it might help to identify systemic associations prior to sometimes to the emergence, particularly in a young child. And if we're talking about a prognostic factor, this is probably the most powerful tool that we have in our armory. Now let's focus on Peters anomaly to illustrate some of the decision process that I use to in dealing with congenital and then by extension, pediatric corneal opacities in general. Peters anomaly is an abnormality in the formation of the cornea during ocular development and is characterized by this posterior stromal thinning, otherwise termed as the internal ulcer of von Hippel. Quite commonly, one can find iris adhesions towards this area. And sometimes, such as in this case here, you can also find a cataract with or without a lenticular adhesions to the back of the cornea. Now, looking at this picture, you will say that, well, the cornea is actually quite clear. It doesn't need a corneal transplant. And I agree. In this picture, the cornea has cleared up somewhat. And there's now been a few case series from Asia stating that over time, by about teenage years, the cornea is so clear that maybe actually all we need to do is to have a conservative approach, observe them, and don't do anything. However, what these reports neglected is that the effect of the opacity during the early stages of life, what they have on visual development and therefore the development of amblyopia. And so almost all the study participants in these Asian series, you can see that they have poor vision around 2200 to ambulatory vision by teenage years. So I think there's still definitely merit in considering some sort of intervention. Now, it's important to recognize that there are two types of Peters anomaly. Type 1, where the lens is clear, and generally speaking, it is a less severe phenotype. In type 2, there's a cataract, and as I mentioned earlier, there can also be a lenticular adhesion as well. And in this slide, you can see the value of ultrasound by microscopy, or UBM, because it provides the important information not only under the corneal opacity, but also under the iris. Corneal tomography or topography, as well as anterior segment OCT, simply does not have the capability to do the same job. And I certainly find this is one of my favorite tools in assessing pediatric, especially infantile corneal opacities. The decision for keratoplasty hinges on a number of factors, apart from just the subtype of the condition. We already mentioned about for Peters anomaly, so we just quickly digress on other pathologies that may be the primary diagnosis for maybe a coexisting condition that we will find in an eye. And these conditions can have strong influence on the surgical outcome. Other prognostic factors include the patient's age and the effects of amblyopia. We just saw a very nice case by Mariana talking about really excellent outcome after keratoplasty. The one good thing about that case was that it happened so late on in the child's age. I think she was about 6 or 7 years old when the scar occurred, and therefore she had ample opportunity to develop good vision before the corneal scarring happened. And therefore, ultimately, the degree of amblyopia was minimal. On the other hand, if you look at infants who had had a corneal opacity for a year or 2 years old, for a year or 2 years of age, and then you think about doing intervention, oftentimes the degree of amblyopia is quite dense at that point, and one would need to kind of ask themselves, is there any value in intervening? I do find that bilateral opacities are more favorable. It's easier for a child to accept amblyopia treatment after surgery. But I think the most important point here is probably the support system for the child. There has to be a very strong commitment to the intensive postoperative management from the family to ensure there's a good surgical and visual outcome. Now, going back to Peters anomaly, this is a sort of summary flow chart illustrating the different treatment for the different severity of the condition. First of all, for type 1, if we're dealing with a mild and visually pretty much non-significant opacity, one can simply observe, and therefore this is where I find conservative treatment does help. When it comes to a moderate opacity, such as a paraxial opacity, or an opacity that is quite small, even though it's axial, I usually prefer to manage these with either pharmacological dilation or by an optical iridectomy, creating a side window through which the child can see through. And this is a video of the surgery of optical iridectomy. I like this technique because I've had opportunity performing this surgery in other areas, such as in Southeast Asia, where the availability of corneal graft is just not so easily available. And also they tend to present late. So you can see, first of all, I perform a peritomy first and then a scleral tunnel, making a paracentesis and then injecting, first of all, acetylcholine and then viscoelastic. In here, what I'm trying to do is to use the viscoelastic cannula to dissect any iridocorneal adhesions, so that when I make the final entry into the anterior chamber, it's controlled. It does not collapse, even though this is only a 3-month-old child. And also the lens is protected by the viscoelastic. Iris is externalized and then excised away with violent scissors, and then the wound is closed. And using this technique, as I said, there is absolutely no risk of rejection, and you can definitely provide a very good visual access, even though it may not be central. Now, for visually significant opacity that is axial and fairly large, sort of a number in the head that I use to cut off is about 3 to 4 millimeters. I think a penetrating keratoplasty is the option. When it comes to type 2, the idea here, I think, is to try to avoid a transplant as much as possible. If the lens is formed, but it is a cataract, or if the lens is stuck on the back of the cornea, yes, one could do a combination of surgical techniques to try to reconstruct and to provide a clear visual access for the child. But none of them are as straightforward as type 1. And I think later on we'll come across, talk about the outcomes, and I think also is not as promising as type 1. In cases where there is either aphakia or lens malformation, the visual prognosis and sometimes even the chances of ocular integrity is at risk. and therefore a careful consideration of risks and benefits should be done before deciding on any surgery. For pediatric penetrating keratoplasty, there are a few specific preoperative considerations. Now, of course, it needs to be under general anesthesia, that's without saying. But having an anesthesiologist who is accustomed to putting a 3-month-old to sleep, I think that's the key bit that you need to find before you embark on the journey. Pediatric eyes, if you have dealt with them before, you will know that they have very high posterior pressure. And if you make an incision, oftentimes the anterior chamber is shallow, collapse. And if you make a big enough incision, then the content comes out, especially iris. So to counteract this, I use intravenous mannitol, and I try to shorten my open sky time as much as possible. The pediatric tissue is also elastic, and I think pharyngeal is absolutely necessary in anyone under the age of 12, if not age 15. And then the trephination, we saw earlier on that the case in the 7-year-old, we had a 8mm trephine and 8mm graft, which is quite standard sizes. However, when it comes to eyes with congenital opacities, oftentimes these are also microcornic. The whole trephine sizes on the small end could be as small as about 5 to 5.5mm. The donut punch I like to oversize by 0.5 or so, and therefore you're talking about 5.5 to 6mm. But you've got to make sure that these are actually available in your inventory before you can actually, again, start on the surgery. So I think quite a few things to think about even before the surgery. We've talked enough about what we need to prepare for it. So this is the video on how I personally do it. This is just before I start, just to give you a background. This is a newborn baby who presented in December or January early this year. The important point here is that she is actually the 9th child in the family. And the family lives about 2.5 hours away. So if you look at the video here, first of all, look at the contralateral right eye. This is ophthalmic. There's no lens inside, and it's actually a primary phakic. On the left-hand side, because of the social situation, I try first of all doing optical iridectomy. I thought there was a small window that I can utilize in the contralateral left eye. Unfortunately, what happened was that after this procedure, the area of the window actually becomes scarred, and therefore I had to proceed with a penetrating keratoplasty. First of all, the first step is actually to do the peritomy. The idea here is to expose the true diameter of the cornea. It also allowed me to put the flowering ring on with 8 phyco sutures. You can see some marking on the cornea already, and the trephine here, I was deciding between 5.5 and 5mm. Ultimately went with a 5, and because it's a 5mm, there's no suction trephine, so it's a manual trephine. I then make a small incision with a super sharp blade. Once I gain entry, I will put in viscoelastic here. Now, I like to use a technique called the cut and cover approach, where I make a small incision, extend it a little, and then put a temporary suture here to prevent intraocular content coming out. As you can see, the anterior chamber is quite controlled here. I did also use intravenous mannitol to reduce the posterior pressure. The trephination is then extended until the graft is, until the host cornea is cut halfway. Viscoelastic put on the bed, and then the future graft is partially secure at 12 o'clock with additional viscoelastic, and then loosely attached at 6 o'clock. I then remove the final suture and then swing out the old graft, and you can see the difference between the old and the new. Quickly secure the donor first, and then proceed to remove the host cornea. And then the rest is history. You just put more sutures in. Because the child at this age was about 6 months of age, I was able to get away with 16 sutures. In 3-month-old, I probably would do 24. The conjunctiva is repositioned, but in a new, more anatomically normal position with phyco sutures. And that was about a month after the surgery when I was removing sutures. Now, during all this time, COVID was also with us. So certainly the penetrating keratoplasty was delayed. Rather than being about 3 to 4 months of age, I have to wait until 6 to 7 months of age. And also since then, it's been difficult to maintain the follow-up because of COVID. And that just shows how important it is to consider all the other things. And sometimes, unfortunately, even though you make all the consideration, you can't control all the factors. But one thing that can definitely be controlled is postoperative management. And really it's the three main things. Number one is immunosuppression, by which I mean what kind of topical steroids we're using. I like to use Q1 hour prednisolone 1% or so. Some people might use Durezol. I'm aware of is intraocular or is potency in causing an intraocular pressure to rise. And therefore I've been rather careful in using that drop. The prednisolone is slowly taper over the course of 1 year. Rarely I use oral or depot steroid injection, but those are usually used in severe rejection episodes. Obviously, we had a case early on just now talking about the use of immunosuppressant in steroid-sparing agent. I think there's some evidence suggesting that they are helpful, including systemic tacrolimus. I haven't used them routinely. I didn't find them to be routinely needed. When it comes to suture management, depends on the age of the child. I think if it's an infantile case, it could be removed as early as 4 weeks after surgery, sometimes even 2 weeks, depending on if they're younger. If they are adolescents or young adults, it could be about 6 to 12 months later after surgery. And I like this simple way of summarizing the strategy, which is that the age of the patient in years is the time to suture removal in months. And I find that quite helpful in calculating some sort of mental calculation. And finally, the close follow-up. This is important because of the management of complications such as glaucoma, cataract, suture-related problems, and also amblyopia. I personally don't do strabismus surgery just because I have 3 excellent colleagues in my facility and also on faculty, Dr. Diemer, Dr. So, and Dr. Penales. There's no need for me to dabble in strabismus, but everything else I take care of on my own. When it comes to refractive rehabilitation, I do the refraction, making sure that the astigmatism is fully corrected with glasses. And also I initiate amblyopia treatment as soon as possible and also as aggressively as possible. But because of this follow-up is so rigorous, the family commitment really is key to success. And it's not unusual for me to see a family several times before the surgery just to kind of audition them to see how likely are they going to come back to a clinic appointment. Now, looking at some of the evidence of the outcomes of pediatric keratoplasty, I think an important one is the multi-center Pediatric Keratoplasty study, or MPKS. This was a study that involved 4 major centers in the United States, included 131 eyes of 106 children. Most of the cases were congenital, and the top 3 diagnoses across the board were anterior segment dysgenesis, which included Peters anomaly, trauma, and infection. And because the majority of them were congenital, most of the surgeries were performed at a fairly young age. The overall survival at the last follow-up, 62% of all grafts at the final follow-up, but among the first graft, it was still a pretty respectable of 58% at the final follow-up. The office did not find any statistical differences between the 3 groups in terms of survival. There were 24 episodes of rejection, which accounted for 50% of the graft failure, as well as a 14% failure responsible due to glaucoma, so due to 7 cases of glaucoma. In terms of vision, there was a definite improvement. At the end of the follow-up, 27% of the children saw better than 2160, compared to only 5% pre-op. But I hasten to add that this does not. This also included the age-related visual development. So if you take that into account as well, maybe the improvement is not as impressive. Now, in terms of complications, 8% of the cases had postoperative infection, a lot of them due to sutures. and which is why I do keep using topical antibiotics until I remove all the sutures. Using multiple regression analyses, the authors show that concurrent surgery, such as vitrectomy and lancectomy, is associated with a high chance of failure. And if you compare that with what we had to do or what we might have to do in a type 2 situation, you can see why the survival rate among type 2 might not be as good. Infection and also intraocular inflammation are also other important prognostic factors for graft failure. In terms of visual improvement, amblyopia treatment, and the lack of or the absence of posterior segment abnormalities are important factors. And I think that's really speaks to itself why amblyopia treatment needs to be aggressive and is so important. Now, this is looking at all the pediatric grafts performed among the 4 centers. When the same authors in NPKS look at Peters anomaly, at the time was called mesenchymal dysgenesis, as well as Peters anomaly and mesenchymal dysgenesis. What they show was that the 1-year survival rate was about 79%. And at 3 years, this was 62%, which again is very respectable. However, a few years later, unfortunately, a much cited paper by Yang and colleague reported some very different results. Among 144 grafts performed in 72 eyes over the course of 21 years in this one center, they reported that the 1-year clear graft survival rate was only 49%. If you look at 10-year survival, it's only 35%. The initial graft survival was just under 35%. I took the liberty to magnify the Kaplan-Meier curves from these 2 studies and put them in the same perspective. And you can see that there is a huge difference in the survival at the same time point. The question is why? Why is there such a huge difference? I've kind of alluded to it already. And I think one of the reasons, it may be because of the subtype of the diagnosis. We already talked about the phenotype type 1 and type 2 being very different. And these 2 publications really show that the survival rate of these 2 subtypes of Peters anomaly are also very different. First of all, Zeman and his team reported that a 90% overall survival in 30 eyes with type 1 Peters anomaly and a mean follow-up of 79 months. 29% of these children saw 20/50 or better, and over 50% of the children saw better than 2100. They did have endothelial rejection, but it was nowhere near as dramatic, or 50%. It was about 17% or so. But half of the children did develop glaucoma. Now, where the second publication comes into play is where I was trained. So this is the experience from Hospitals of Sick Children or Sick Kids Hospital in Toronto, and the results have now been accepted for publication, yet to come out. The experience really is mirrored in sick kids, where type 1 also has very excellent results, about 75% survival at 10 years. The additional information here is that you can see the type 2 was rather disappointing. At 10 years, the survival rate of type 2 Peters anomaly after a penetrating keratoplasty was only 39%. Now, that figure is very similar to what Yang and colleagues reported. So I think there's some explanation to why those authors saw very different results. Now, looking at the visual outcome, again, this is data from Sick Kids Hospital from Toronto. One can easily see the difference, again, from because of the influence of the disease subtype. With type 1 on the left-hand side being very good outcome, some children saw, in terms of mean vision-wise, some children saw up to 20/50 level. In type 2, at best, is probably at the level of 2200, but many more was only able to have ambulatory vision, if that. When it comes to the sort of aphakic or lens abnormality, very severe phenotype, most of them just have light perception vision, which is why I think the risks and benefits should be carefully considered before embarking on surgery on a third subgroup. Now, these are guidelines, and guidelines are guidelines, and there are times when one have to work outside them. For example, this is one of the children that I come across where the right eye, even though has a more favorable anterior segment phenotype, unfortunately, there was no visual potential. And therefore, one had to consider doing something on the left eye, which even though the anterior segment is less favorable and the graft might fail, but it really is probably the only chance this child can have to see something. Let's switch gears a little bit and talk about the role of lamellar keratoplasty in the pediatric setting. This is a surgical area that I'm quite interested in because of the challenges that it presents. And shown here is a case of herpetic stromal scarring. You can see that it's fairly deep with quite a bit of corneal vessel as well and irregular corneal thinning. What I find is that in these ones, I like to, first of all, mark the scarred area so that I know where are the so-called no-go zone. And my preferred method here is to perform a manual layer-by-layer dissection. In here, I was surprised that the Moria adjustable tree fine didn't do any cutting at all, so I had to resort back to the old-style Hasberg-Warren tree fine. Now, apart from herpetic scarring, another big cohort of children that I have to operate on is actually Flectenola disease, and they also have very extensive scarring, very deep scarring, and very debilitating symptoms among children who are 4 to 6 years of age and photophobia and so on. And those two are really sort of like conditions that burns my fire and try to find a better way to treat them. Now, I speeded up the video here because I agree it is time consuming to perform a layer by layer, but it does remove the uncertainty associated with a big bubble air dissection in these cases with extremely deep vascularized scarring, and also makes it easier to provide a good anatomical and visual outcome without the unnecessary risk of perforation and endothelial rejection. This particular case, I took the advice with by Dr. Chayat, actually. We were talking about what to do for today, and then I was taking the advantage to say, hey, what do you do with this case? And you can see that I did most of the surgery actually sitting temporally. And I think that was the publication that he did while he was in Stein. So talking about passing the torch from one person to another. Towards the end of this case, I did a fine needle cautery to remove some of the blood vessels as well as intrastromal bevacizumab. And I've seen her last week. This is day 5 and pretty happy with 70 microns left. I think she'll see quite well, given a bit more time to follow up. But certainly a condition that it will be, the story that will be continued. Let's see how it goes up. Now, another reason why I prefer to do a manual dissection instead of air dissection is because of this influential paper from Great Ormond Street back in 2010. In this particular publication, they included 13 eyes of 11 children. 5 of them were diagnosed with mucopolysaccharidosis, and a condition that I'm seeing a few trickles now into my practice. What the authors found was that the air injection of big bubble was not very useful. Number one, they couldn't really visualize the cannula or the needle, and number two, it seemed to be rather unpredictable with this particular condition. They resort to either using the UBM to guide them. Nowadays, we use intraoperative OCT, so I guess that's an advancement over time, or physical dissection. 2 of the 13 eyes were converted to penetrating keratoplasty. And I think probably this is one of the most challenging cases that I had to deal with. It just doesn't behave as the usual lamellar dissection that I have to do. But I certainly enjoy them. Now, I would say that I might be changing my mind about air injection. Obviously, seeing today's case by Dr. Chai looks really amazing. And also this recent report from Italy, who looked at a big bubble in 14 eyes of 13 children. Now, obviously, notably, these children are slightly older. They are usually in their teenagers, and therefore their diagnoses were mostly keratoconus rather than anything else. But the big bubble success rate here was just phenomenal. It's like 93%. The only notable failure in this cohort, the one case that they could not get a big bubble, was herpetic scarring. And as I said, is probably one of the most common reasons why children come and see me. So I think I'll be choosing my needle wisely to see which case I will do. But when it comes to come across a keratoconic case, I might not be so hesitant in doing big bubble dissection compared to in the past. Now, in terms of endothelial conditions, I think DSEC are increasingly being used in pediatric setting now, whereas DMEC in children is still quite new and has not been extensively reported. In this review, the two biggest series were by Massimo Busin and also Dr. Ramappa. Together, they reported 29 eyes, and quite a few of these patients did well. The one limitation, unfortunately, is that even though the astigmatism is all better and also recovery is faster, because of the residual stromal haze, the vision and also the refractive error at 1 year spherical equivalent is about the same. There was no difference in this particular study by Asher and colleagues compared to penetrating keratoplasty. This is a short video that's talking about an EK that I did about 2 years ago. I probably won't run the whole thing because of time. This is a 13-year-old boy with a decompensated right cornea. He had congenital cataract surgery and AC-IOL insertion age 3. This lens became dislocated in 2017, causing secondary glaucoma and corneal edema. Unfortunately, despite explantation of this lens, the corneal edema persisted. His visual acuity was hand motion at presentation, and he has a painful right eye. His other issues were posterior corneal scarring, limited decimate detachment. There was also a thick soldering ring obliterating the sulcus space. One of the amputated haptic was stuck in the inferior angle, and the pupil was chronically dilated. Because of developmental delay and the presence of glaucoma and aphakia, I wanted to avoid a penetrating keratoplasty. I decided to do a two-stage procedure. The first stage is to compartmentalize the anterior segment from the posterior segment. In order to provide a location for the intraocular lens, I decided to tackle the soldering ring. Once the IOL was inserted, I used a retractor to enlarge the capsular opening so that I can then optic capture the intraocular lens. I let the eye settle for 5 weeks before proceeding to stage 2, endothelial keratoplasty, or more precisely, a DSEC procedure. So in this case, as I said, with time considered, I won't play the full video. You can see that in the OCT, the clear decimate detachment. I prefer to use the endoglide system to insert my DSEC graft. And quickly speeding to the end, I was able to attach the graft. I didn't need to rebubble this child, and he's done pretty well. After 2 years, his graft has remained clear. The problem actually is glaucoma, which is pre-existing, but now it seems to be getting worse. So I might have to do the unthinkable, which is putting a tube in this eye. Let's hope that he doesn't need to get that far. Now, in the last few minutes, I thought I would just brush upon about the subject of keratoplasties in children. One of the largest pediatric series was by Aquavela and colleagues in 2007, in which 22 cases were performed. Remarkably, they had a 100% retention rate in this cohort. However, if you look at the actual follow-up, it was only 10 months, and less than a third had visual outcomes reported, ranging from 20-30, but mostly count fingers or so. Nevertheless, this report spurred on a number of surgeons to take up the technique and apply in the pediatric cohort, some of them as the primary source of surgery. However, interestingly, about 10 years later, when I was training in sick kids, I found that relatively few reports actually emerged after that seminal paper. Therefore, I took upon and looked at a multi-center analysis in Canada, including 11 eyes of 11 children, and 6 of them were primary procedure. What we found was quite different, and unfortunately is disheartening. because we found that about 55% of the children actually did worse in terms of vision-wise at 2 years compared to pre-op. And by a mean follow-up of 42 months, the retention rate was only 36%. Furthermore, once we look at the literature as well as our own series, we found that there was an unacceptable level of complication that is severely sight-threatening. These included endophthalmitis, retinal detachment, and the loss of light perception, all ranging about 20% or so. About 14% of the eyes became physical. And since the publication of the paper, a number of very prominent surgeons from various parts of the world came out and shared similar stories. And it seems that unfortunately, nobody had a good idea how to make this work currently, and negative results didn't receive the needed attention that it deserved. And until I think we know the full story, right now, I would not recommend the usage of K-Pro among children. So in summary, I hope today's talk gave you a sort of an overview on the wide range of clinical entities one might see among pediatric corneal opacities. The corneal transplant outcome is specific to disease and disease subtype. There are important adaptations to minimize intraoperative risks. Newer transplant techniques are being transferred from the adult to the pediatric setting, but I think ultimately dedicated perioperative care is vital to graft survival, visual outcome, and also how the child develop in the long run. Thank you very much.
Thank you so much, Simon. It was a really, really good presentation, an excellent update, and congratulations on everything that you are doing. I hope that Dr. Brown is still with us, and maybe he can join us. Dr. Brown. So for those who may not know Dr. Stewart Brown, as Dr. Fung mentioned, he's probably considered the father of corneal transplantation in children. And I was very lucky to be his fellow in NAC. Dr. Brown, how are you? I think we need your, how are you doing, Dr. Brown?
Excuse me?
How are you doing?
Well.
Nice seeing you. So let me introduce you to Dr. Fung.
How are you?
True honor, sir.
Of course, thank you.
So yeah, so I was a fellow with Dr. Brown in 1987, and I saw a lot of corneal transplantation in children. So let me ask you something, Simon. So do you do a lot of corneal transplants in adults as well?
Yeah, so I have a very interesting practice where 90% of my patients are children. I do adult as well, and these are mostly kids who grow up to be adult. They didn't stop become patients. They are still patients.
Right.
And really that's what I like to tackle with. So a lot of these are congenital glaucoma, endothelial decompensations, etc., or multiple failed grafts. Because
I mean, it requires a lot of skills to do all, like lamellar grafts and
absolutely.
In children, and so you have to have a really strong background in adult corneal transplantation, which you have. So how common is these days to do lamellar transplantation in children? Is that something that is being done in most centers, or just few surgeons are doing it?
I would say a few centers, certainly not many. I think number one is that the awareness of lamellar surgery in children is still yet to catch up. I think even, especially in America, in the United States, lamellar surgery itself, unless you're talking about endothelial transplant, doesn't really get the attention anyway because of the time-consuming situation, and also because of the issue of reimbursement. So when it comes to children, it's going to be even harder. It's just that I happen to have this interest, and I like take on challenges, and therefore it's becoming a referral center. And I'm seeing once every 2 months or so that I need to do a lamelograph.
Wow. So they're referring you these cases from all over the place because you have this experience, this unique experience.
Right. And also because of the cohort, I have found that in this region, in Southern California, there's a huge cohort of Flectenola disease. I actually believe this is also another area that Dr. Brown knows very well. The Flectenola diseases, and they are very debilitating, causing a lot of scarring. And therefore gives me the opportunity.
Excuse me, I didn't hear. Was that Flectenola?
Yes, Flectenola disease.
Well, you know, if I can I say something?
Yes, absolutely.
Of course.
Well, with Flectenola, I would caution against lamellar.
Oh.
And the reason is that I can show you case after case of Flectenolas, which I see quite a bit.
Mm.
The interesting thing is, there's many interesting things about them. Whoops, I didn't know whether, here I am. One is, not directly to that point that I was making, is that the parents have rosacea.
Mm.
And one of the parents has rosacea. And these cases, when they get a little older, often when you treat them with, let's say, tetracycline, et cetera, they clear quickly.
Mm-hmm.
But when you don't, of course, you see them early and they have superficial vascularization, they have superficial scarring. But the advantage of these cases is that they're young. And when they get to be about 11 or 12, the cornea clears remarkably. So I've had case after case when there was dense vascularization, dense anteriors scarring, apparent scarring, that clears to 20/20. 20/20.
Oh, wow.
Now, in sunlight or bright light, they see less because there still is a slight haze. But they see well, they go to school, they've gone to college without glasses. And the advantage, again, is that when they're under 10 or 11, these kids, when they get older, have the advantage of clearing their corneas. And we've seen this over and over again with young kids with congenital conditions as well as scars. So when they're young, they have the ability to remodel and become transparent. So I would caution on doing it. And you don't want to give them tetracycline when they're young because it changes their teeth.
Right.
But or drugs like that. But when they get older, it goes away. The condition goes away. It disappears, and when it disappears, the scars go away. Wow. And time again, I've seen it.
That's good to know. Clearly, I need to watch out more. Need to observe them more.
Wait a little longer.
That's right. That's right.
Excellent. I don't know if anybody in the audience have a question, Dr. Pincus, Dr. Valdez, anybody? I have one question regarding. So, Simon, which would you say is your number one reason for corneal transplantation these days in children? What would be the number one diagnosis?
I still find that congenital opacities is probably more common.
Like Peter's
Yeah. I mean, yes, we do see a fair bit of trauma, but not every trauma causes bad enough issue that needs a corneal transplant. I also like to trial contact lenses and all the non-invasive stuff first, And some of the children are remarkably tolerant, and they see very well with contact lenses, and therefore there's no need to intervene surgically. So I do find that actually, yes, congenital or Peters anomaly in this particular regard is probably still the more common reason why one had to do something about it. You know,
It's much more common than people realize.
Oh yeah, absolutely.
Yeah, much
Absolutely.
more common.
Dr. Brown, what is your long-term experience with corneal transplantation for Peters anomaly?
Well, it really depends on the origin and how the eye was before. So, for instance, when you have a unilateral Peters with a where the scar doesn't significantly go to the periphery, and when it does, you can get glaucoma later on, if not immediately after the surgery. But when that is minimal, we have 14 cases and with one failure. And the vision ranges, this is what's so remarkable. All these eyes, when they're unilateral, have a they're smaller than the normal eye.
Right.
A little smaller, uniformly, every one. And our vision ranges from 20/70 to 20/20, and postoperatively. And so the majority are between 20/40 and 20/20. And this is for 20 to 25 years post-op. So that's a great case. You see when you grab it.
Yeah.
However, when they have had either glaucoma after surgery or before surgery, and that changes things.
Yeah.
And but still, you get about 40% who will last quite a long time, 40–50%. But the eyes with the glaucoma, at least in my tenure, have had poor experiences.
Yeah.
And been refractory to glaucoma procedures, except for things like cyclodestruction or some awful things like that. And in those, I've got cases that have lasted 30 years, but not all.
Yeah. And I agree. I think experience from sick kids, what I saw and what I experienced is very similar. We talked about the subtype and survival in the presentation. In the same publication, we looked at the presence of glaucoma and survival. And as soon as you get glaucoma, the survival just dropped like a stone. And I think that really is the sort of next challenge is how do we then, we can treat rejection, we can treat cataract. How do we control that glaucoma or the risk of developing it? That really is a key.
Simon, do you think, changing a little bit the subject,
and when their sibling has it, glaucoma, they almost always get it also.
Yeah.
Simon, I have a question, changing a little bit the subject. Do you think children with astigmatism, when they show up in your practice, should get topographies every time they come, especially, for early keratoconus detection? What do you tell us a little bit your experience in earlier keratoconus detection, and if by educating the parents and the children to avoid eye rubbing, are you finding less progression in your practice?
That's actually a very very topical and very interesting question. So as many of you know, United States recently have the cross-linking. And that actually created a new wave of trying to recognize the condition much earlier. And therefore, we have seen an increase in uptake in terms of referring for early screening for keratoconus. I've had referrals looking for keratoconus in a 13-month-old before. Obviously, it's not going to happen at that age. If there were anything, it would not be keratoconus.
When do you start seeing keratoconus? Like, what's the average age like in the bad cases? What time they start?
Yeah, I would say at least teenage. Like you're talking about 14, 15.
Oh wow.
We have seen younger, like the youngest that are true keratoconic in the child. The youngest I've seen is about 8 years old, 9 years old. There could be associated issues such as vernal or allergic eye diseases. There's almost always some sort of eye rubbing element to it. If there is trisomy 21 or Down syndrome, again, we tend to see them too. So the usual risk factors that we know about, yes, they could be much earlier. Now, when it comes to sort of progression, yes, I think you kind of alluded to it already. They can present quite severely. I have a case right now who is a teenager, 14 years old. The first time I saw him, one of his eye was already 300 microns. And the K reading was like 75. There was no way cross-linking was ever going to happen. I also have about 3 to 4 cases now where we diagnose them, we give them anti-allergy medications, they're not itchy anymore, they stop rubbing the eyes, they are stable after 2 years. No cross-linking.
Right.
So I think the eye rubbing element is huge. And I think if you listen to other people such as Gatanel from Paris, they don't even believe in cross-linking. So I think there's something there to talk about whether one should intervene early or later on, and how you can actually control the environment to make it less likely to progress.
Arturo, if you remember, while you were a fellow,
yes,
we were very, and it was soon after I arrived in San Diego. We saw very young, mostly Latinos.
From Mexico, yes.
From Mexico that had advanced keratoconus.
Correct.
5, 7 years of age, sometimes with high drops. And I still see those. And it always seems to be Latinos.
I remember that we were doing some studies, Dr. Brown, to see if there was an issue with the atmospheric pressure, because most of them came from places with high altitude, like Mexico City. And I have a fellow who is now, he's probably one of the doctors who have done more cross-linking in the world. In Quito, in Ecuador, Dr. Christian Sancho. And also I have friends in La Paz, Bolivia, and they told me that 50% of their patients that come for refractive surgery, they have keratoconus.
Oh, wow.
So yeah, so there's definitely a higher incidence in people from higher altitudes. And I think the patients that Dr. Brown is referring, I remember they were mainly from these cities where the altitude is over around 6-7, it starts at 6,000-7,000 feet of altitude, which is around.
And we theorized that they had the condition, but when they had keratoconus, the genetic predisposition, but when they were in higher altitudes, it started earlier because there was pressure on the eye to expand, the cornea to expand. And we still see them. And the funny thing is, most corneal surgeons don't recognize it because these kids are so young. I mean, when they see them very, very advanced, they say they can't be keratoconus.
Yeah, so I'm always asking, Dr. Valdez, our ophthalmopediatric, that we should include a topography screening in as many patients as we can, especially that we have so many topography systems in our institute because of we are heavily doing refractive surgery. So it may be interesting to see, what's the incidence of keratoconus in children younger than 12. So, I don't know that answer, but maybe in the Latino population is more common.
Yeah.
Maybe more common, but it may also be that those that have it would not be showing up if they didn't have the other pressures.
Right.
Well,
Dr. Pincus, you wanted to ask something?
Yes. Thank you for your talk, Simon. So I wanted to ask if we have two scenarios, two different patients. If you have a congenital affection and it's unilateral, when is the perfect timing for doing the surgery, a corneal transplant or whatever surgery the patient needs? And in another scenario, if you have a 7-year-old child with a unilateral disease of the cornea, and that if you feel or you think that risk of amblyopia it's lower, do you prefer to wait till it gets older? Because maybe I think that's something difficult to decide when to say yes, I have to do the surgery, and it's responsibility of the surgeon and the patient and the patient's family. And so they should be very aware that they have to come frequently to their checkups, and that if something is bothering the eye, the patient has to go to examination. So I don't know, do you prefer waiting in that case? And I mean, what's the two different, those two scenarios?
So I'll tackle probably the second scenario first, which is the 7-year-old unilateral corneal opacity, and you said that it was congenital. So the fact that
in that case, it's something acquired. I mean, it's just, I mean, it was fine. It was maybe a trauma, a scar, or a herpes or something like that. It's not congenital.
Oh, I see. Okay. So, if it depends on everything that we talked about, but I think the first thing is whether vision is actually good enough, right? If you can actually afford a transplant, I would. Surgically speaking, 7-year-old is going to be less challenging than an infant. So that's not really the reason why I would hesitate. The reason I hesitate is whatever graft we're going to do is going to have a limited lifespan. And therefore, if we can afford doing one, then I would certainly try one. Amblyopia in a 7-year-old, I would say, is probably a lesser concern compared to the other scenario where it's a baby, just because they are already sort of towards the end of their visual development or the critical period of visual development. So if they are, let's say, had a penetrating corneal scar from trauma, 20/40 in one eye, I would try contact lenses. I would try simple things. I would not necessarily jump in to do anything just because the scar is there. Now, if you are talking about the same case, but vision of 2400 and not going to be corrected by any means, I think that's reasonable to try. Now, taking on the other scenario, which is the sort of young or infantile case, congenital, unilateral. Let's say they are all going to be compliant. They're superstar family. They come every day, no problems at all. And you've decided that yes, this is not going to clear on its own. This is just far too big. The 6 millimeter cornea is involved in the center. Okay, there's no way you can do an optical iridectomy. In those patients, I would like to do as soon as possible. When I say soon, I mean 3 months or so. There's a delicate balance between sort of the 3 months of age or later. Earlier than 3 months, if you do pediatric cataract surgery, which I also do as well, some of us do it at 6 weeks of age or even earlier for unilateral cataract, like 5 weeks or so. I think doing a corneal transplant at 5 weeks is very challenging. The tissue is just too elastic. The anterior chamber is not controlled. And then creating open sky is just going to create problems. At the same time, if you go beyond the 3-month mark, then the nystagmus can happen. And as we know, with nystagmus, then you start to have irreversible visual deterioration in the particular eye. In a unilateral setting, you'd also get a reduction of vision that no matter how much correction you do, you may not ever get back with amblyopia treatment. So I think 3 months is probably a good window where it's not too early and not too late. You still give them the ample opportunity to develop vision, but it's safe enough to do a corneal transplant. Yeah.
Great, thank you.
Simon and Dr. Brown, you have many things in common besides. Dr. Brown, I believe I remember you are a big Laker fan, correct?
Are you speaking to me?
Yes.
I am. Yeah, I am.
So let me tell you what you guys have in common. You are Laker fans. Dr. Brown, you were also training in Moorfields, if I recall correctly. Correct?
I spent time there. Yes.
Oh,
Yeah.
wow.
You were in Moorfields, and then your favorite fellow was Dr. Mondino, correct?
He was not my favorite. You were.
Well,
but he is a close friend.
So once COVID goes away, Simon, I would like to invite you to come here to San Diego, and we will go out for dinner with Dr. Brown, and you can meet, and talk more about. Because
Wow.
this is fascinating, I think.
I can't turn that down. That's just too good to be true.
Can anyone go out to dinner? God, I mean, anymore?
Yeah, we will have to wait until COVID is gone.
Yeah.
Whenever that might be.
Let's do that.
Let's do that. That would be great. That's a date. Thank you for offering.
Anybody else have a question over there, like, or any comments from any
Yeah.
of?
Yes, I'm Dr. Valdez here.
Hi.
Yeah.
Here. About the topography, Dr. Chayet, I usually do it above a cylinder above 3, or myopia, or when it's combined with myopia.
Mm-hmm.
Not because I suspect about keratoconus, even if they are very young, but just to have a baseline. If they maybe developed it older, in an older age. But I used to live in Mexico City, and I did not see so much keratoconus as I saw here. So I think the allergic factor is very important. Or maybe, yeah, I believe you about the altitude thing, but yeah, maybe the Latino factor can be very much important that maybe we think. Yeah. And I have another question for Dr. Fung. What would be the visual acuity cutoff that makes you decide to make keratoplasty in a patient in the amblyogenic period? Let's say corneal scarring because of trauma, and what would be the visual acuity that you say, yes, I'm gonna make the keratoplasty?
Right. So I'll respond to your first part first, because that's an interesting comment.
Could I interrupt for a second? Yes. I have to leave, and I enjoyed your talk.
Oh, thank you so much.
And I enjoyed seeing you, Arturo. Say hello to your family.
Thank you.
Thank you so much.
The same way.
Big hug. Okay. Good night.
Good night. So, Adriana, I'll respond to your first part first, because I think that's actually also an interesting comment. With the US being a reimbursement model, we cannot always perform topography or tomography for that matter. So actually one of my go-to tool in my clinic is the retinoscope. So because I do refraction myself, so I would actually seek out the irregular astigmatism. And I think there's now a few papers who said that it's fairly sensitive, nowhere near as, like a tomography, like a pentacam or something, but at least you pick it up. So I think, in terms of numbers wise, yes, 3 would be a nice number. We consider that to be pretty high, and also look at the quality of the Myers. If it's going to be a little bit scissoring, and it's got a full cycloplegia, I'm like, that might be something that I need to look at to next time. About your second question about the sort of the vision cutoff, I think it's really a difficult one, because when we do corneal transplant, I'm nowhere near as good as Dr. Chayet. I can't get 20/40 every time. So I don't think I can set a number, say, oh, 20/40 because you don't meet the DMV driving criteria, let's go for corneal transplant. I don't think I can quite do that. But I think, 20/50, 20/60, and it's not improving with whatever refractive means you have, glasses, contact lenses, whatever. I think it's worth having that conversation. If there was clearly a corneal component that you can see that, look, it's not improving, then I think it's not unreasonable to offer something. My sort of limit, I would say, of my surgical skill probably is the level of amblyopia, which is 2 line different compared to the normal eye. I think if 20/40 would be my cutoff, I would disappoint a lot of people. Yeah.
Talking about that, Simon, thank you for the answer, but what's your take on doing refractive surgery to children? Keratorefractive surgery or any type of surgery? Tell us about it, because there's a lot of controversies. Like in Latin America, they're more aggressive, and they do LASIK, and sometimes there's a question about ICLs in children for amblyopia. What do you think about that?
So I've done PRKs before in children, and not so much LASIK, and I'll explain why in a minute. The PRK situation again was during my fellowship time, when we actually had the PRK laser itself, the excimer laser, in the OR, and we can therefore actually perform, basically a PRK treatment for children, not necessarily just high refractive errors, but high refractive errors due and associated with developmental delay. They're not going to wear glasses. They're not going to wear contact lenses. There's just no way that they can get out of that, what's termed by Larry Tyson, this visual autism. They can't see, they can't wear glasses though, and then they remain can't see and become, uncooperative. So we've done a few of those, and I think those do quite well. Obviously, with the usual precautions apply, make sure there's no ectasia beforehand, and make sure it's thick enough, you don't overtreat, all those stuff. And also, we're not necessarily aiming for a perfect 20/20 outcome. We're aiming for maybe a reduction of the refractive errors. When it comes to LASIK, we felt that it's a bit unsafe for this particular subgroup of children, because we didn't want to deal with eye rubbing. If there was an eye rubbing issue and then you did a LASIK, you can see where it's going to head to, right? The flap is going to dislocate, and then it's going to cause problems. So maybe not so much LASIK. Now, when it comes to ICL, I think it's now a new area. And a lot of the refractive work in the United States is sort of pioneered by Larry Tyson in St. Louis. And I think he has a paper on ICL in this very particular subgroup of children, developmental delay with high refractive error, or just amblyopia with high refractive error. I haven't personally done it. I'm actually exploring to see if I get enough children to do. But I think it's a very attractive option. I think it's doable. And the good thing is, in a way, is reversible in a way. There's always the refractive lensectomy that you can do if it does become a cataract and you're -20 anyway. What is there to lose? So I think, yes, I think it's we're going to see more and more. We don't have EVO, unfortunately.
The point you are talking about specifically, those type of huge anisometropias, where is either that or the patient walks with the -20 without any correction.
Exactly.
How about for a -8 9-year-old to do SMILE? You take it to the OR, and then it's just one procedure, very simple. What do you think about that?
I think whatever you do as a pediatric surgeon, whatever you do I like to make sure that what I do is can stand the test of time. So it's obviously attractive, and I think it would work well, certainly in the immediate term. I just haven't seen long-term data, and I'm a data-driven guy. I've presented a lot of data because I want to know how we can be guided by these things. So right now, I wouldn't feel so comfortable just because the technique is new, and I don't actually know what would happen. One thing that I would kind of immediately come to my mind is that children have a stronger inflammatory response, and you are creating an interface by doing the smile and your manipulation. I don't know how much interface haze or whether that has anything to do with an unsatisfactory outcome. I would like to see some evidence.
Very interesting. I agree with you, but yeah, so you feel very comfortable from what I hear with PRK.
Yes, because you kind of, you know what you're dealing with. We had plenty of trials, and PRK, when we did it in Toronto, we combined it with mitomycin. So it wasn't just PRK standalone.
Correct.
It's a little harder in UCLA just because we cannot really get that laser in so easily. So haven't done since.
Okay, very, very interesting. Anyone else? Dr. Luis Valdez, is there any question from the public or any of the fellows? You want to ask something? This is the right time. We have a few more minutes. Maybe we have like 3-5 minutes more.
Sure.
No, there's no questions in the chat room.
Okay, any questions from any of the fellows or anybody else wants to say something?
Before anyone asks a question, I just want to say thank you so much for the opportunity and the platform to share my knowledge and skill with so many of you. I'm amazed and blown away by how many people turn up to an evening webinar on a Wednesday evening. So I'm truly honored.
Well, Simon, let me tell you something. I was very impressed with, I met you through Keranet.
Yes, yes.
And you always are very, your opinions and advices that you give are very unique and very, very nice. So from the beginning, I was very impressed with you, and that's why we decided that it would be great to have you here. And it couldn't be better. You brought all the newer stuff on Pediatric Keratoplasties, and then we had, Dr. Brown, which I think this is going to be a legendary video. I mean, it's recorded, so we'll have it. I think it's unbelievable, really, and I think that's something that you need to reach in. You need to keep working for 50 more years, like Dr. Brown.
Yes.
And
I need to carry his flag.
Exactly.
I think that's the important thing, is to continue that legacy. I mean, from him to Dr. Mondino to you, and then now, it's funny how things go. Coming back to here UCLA, yes, I think that will be a very, very interesting dinner. I'll definitely hold his word for it.
Fantastic, and if we will love to send you any of the patients that we need to send you for anything that you do that we don't do here, but maybe in the future we can also do some interactions and do a few works. By the way, the publication of that we did with Dr. Mondino, one of his ex-residents came for a visit during Dr. Smith, Ronald Smith.
Yes.
Came to visit us in Thanksgiving of 1998, I believe. So there was a children there, and I couldn't start operating because of the general anesthesia.
Right.
So I told Ron, hey Ron, what do you think? Can we just do it temporarily? He said, yes, let's do it. So I started temporarily, and then I had another PKP. The next one I do it also temporarily. I say, why don't we publish this? Why don't you talk to Dr. Mondino, and we should. So and from that time, we always do our surgeries temporal. I went to visit Dr. Mark Terry in Portland in 2010. And he was doing everything also temporally because he said that all his endothelial surgeries were easier temporally. So he decided to just move everything temporally. And, you know, it makes a lot of sense. I don't think there's any difference in terms of astigmatism, but I think it's just easier.
Yes, yes. Certainly it was easy for that case because I had to. I had to.
Well, thank you so much. It was really an amazing webinar. I think it was top notch, and I'm so happy that we were able to make it. And I look forward to see you again, to maybe one day pay a visit. Maybe one of our fellows would like to visit you whenever this COVID things ends.
Yes.
And I know there will be a lot of interest of people who, you know, are interested in doing children transplantations. I'm sure they will call you for everything.
Sure, absolutely. Thank you so much again for having me tonight.
Okay, thank you, and goodbye to everybody, and thank you everybody for being here with us today. Bye bye.